I'd like to introduce a good friend, Dr. Jesper Jensen. He comes to us from Aarhus, Denmark. I first visited Denmark in 2011, and we've had tremendous collaborations in the field of TAVR, coronary CTA, and FFRCT, and I've really learned a significant amount from both Jesper and Bjarne and many others in Denmark, particularly around the integration of FFRCT. I asked Jesper to highlight some of his really interesting and compelling work looking at the expansion of coronary CT into a higher risk population supported by FFRCT for lesion-specific ischemia adjudication. These are data and the experience that he published recently in European Heart Journal Cardiovascular Imaging. So without further ado, thank you again, Jesper, for obliging us, and look forward to your talk.
Thank you, Jensen, and thank you for your nice presentation. So, hi everyone, and thank you also to HeartFLow for inviting me to give this webinar. I hope my voice is clear to everyone, otherwise you're not able to kind of tell me, but I hope that you can hear me. This is the title of my talk today, and I should start off with my conflicts of interest. I only have one, and I don't have any financial disclosures regarding HeartFLow. Let me start out with asking you guys a question. Just let's take a case. A 65-year-old male patient with stable classical angina. His echo and ECG are normal. He's on relevant medication. However, as he says, things could be better. So I would like to ask you what to do next. And please, when answering this question, just tell me what you would do at your institution. Would you go for optimal medical treatment and a stress test? Would you go for ICA on top or CTA? Okay, so it's kind of a little bit 60-40 on stress imaging and CTA on the rest, and nobody would go for ICA. Okay, that's interesting. So let's have a look at what guidelines tell us. At least the European guidelines. I'm from Europe, so I'm most familiar with these. I know the American ones are a little bit different, but at the end of the day, they almost say the same thing. But this patient would be in this category. He would have about, I would say, 82% of pretest risk according to the Diamond-Forster risk algorithm of having significant coronary artery disease. So what do guidelines tell us? Okay, this is rather small. I hope you can see it here, that the patient is here. And guidelines recommend us stress imaging. So most of you guys are right. However, some of you are wrong because you say that we should go for CTA, which you definitely should not do in such a patient. So that's interesting. So what do we do at our institution? Well, we definitely do not go for MPI. We don't go for ICA either, not anymore. We go for optimal medical treatment and coronary CTA. And one of the reasons why we do this is, of course, that we got FFRCT on board now. Not the only one, but an important one. I should kind of share with you the CAD testing history at our institution, because otherwise you're kind of not aware of how we do things. So we have been doing CTA as a frontline test now in low intermediate risk patients for, I would say, more than 10 years. And only in the event of until May 14 that we find intermediate lesions, we would order an MPI to find out whether we should send the patient for cath. If we found a high-grade stenosis, we would usually send the patient directly to ICA. That's what we did. Then, as of May 14 until today, we adopted FFRCT into our clinical practice. That was due to Bjarne, as Jensen mentioned before, my good colleague Bjarne Nørgaard, who was the prime investigator of the NXT trial. The experience that we harvested with FFRCT, we thought that this was a very promising test, so we adopted it into our clinical practice. And at the moment, we use it for two different clinical indications, either as a gatekeeper to the cath lab in intermediate lesions, or we use it as a supplementum to an already planned ICA, a high-grade stenosis. This is how we do things now. It hasn't always been like that. So I would like to go through with you how we sort of got there. Because otherwise, it doesn't make sense just to start talking about high-risk patients. I don't think so. So bear over with me. I will go through what we have learned until now. We report our first initial results in this paper by Garner and co-workers. We use this scheme defining high risk as left main disease, proximal LAD, or three-vessel disease. Intermediate risk was anything below that. At least it should be one significant stenosis, more than 50%. And low risk as less than 30%. And accordingly, we agreed to do like this over here. And we interpreted FFRCT in a dichotomous manner, as you can see here, rather conservatively. So in this study, we included kind of I would say 1 year of coronary CTA production in our institution, a number like this. Most of them we were able to give contrast, and most of them were sent home as expected. We sent the patient with the highest rate of coronary artery disease directly to ICA. That was how we did things in the old days. And the patients with intermediate lesions we sent to FFRCT as we agreed upon. And these patients, they were, if you can see these numbers, they were in the appropriate range of pre-test risk according to at least European guidelines. They were low to intermediate range. So fair enough. What about the patients going to FFR? We had an acceptance rate of 98%, and 57 patients had a significant result according to how we defined this at that point. Most of these patients were also sent to ICA. And moreover, a lot of them actually also had FFR or IFR done. Of course, you can't use this for kind of accuracy measures, but anyway, it kind of tells you a little bit about the signal in this. At least it told us that if we used a cutoff point of 0.74, we would have very few false positive results. On the other hand, if we used 0.80 as we agreed upon, we would have quite a few of the false positive results. That was one important learning from this study. And also we saw that the rate of revascularization was fairly low in this group compared to this one. And of course, this was due to the fact that these patients a priori had more coronary artery disease. And also another interesting finding in the study was that the FFR guidance was rather high here. We saw a declining tendency over time in this study, meaning that probably that our interventionists kind of grew familiar with FFRCT as a concept. So this led us to introduce this as the so-called Aarhus FFRCT decision rule algorithm, which we still use, although in a quite modified version. Still start out with finding the anatomic substrate for disease, of course, and then you stratify patients into high and low risk, and in the intermediate range, we recommend FFRCT, or we recommended at that time FFRCT. And then, in accordance with the results that I just showed you, we recommended ICA in the event of an FFRCT value below 0.75. This was how we did at that time. And in the gray zone, we recommended optimal medical treatment. So, having performed this, we thought, okay, this seems feasible. Now let's look at what has this kind of change in our paradigm going from MPI previously on over to FFRCT. How did that actually influence our downstream diagnostic workflows, especially invasive angiography? This is what we report in this paper, also by Bjarne and co-workers. Here we use the same schema as I showed you before, however a little bit modified because we of course took into consideration the results from the previous study that only influenced a minority of the patients in this study. We looked at patients from 12 months before we started out with FFRCT, 8 months after as a kind of rule in, and then we looked at an FFRCT steady state, I would call it here, another 12 months with FFRCT. We saw a an increase in pretest risk. It was significant. However, it was there. Not that big, but it was there. This indicated probably that we got more familiarized with FFRCT and dared to venture into looking at more high-risk patients. So this also could be seen from this slide that shows you the action scores over time increasing here. So this supports that we were probably looking over time on more diseased coronaries. And the results were that, of course, as expected, the use of myocardial perfusion imaging dropped dramatically. And in Denmark, you have to return to the hospital for another test at another time. So this was very, it was a good thing for the patients that they didn't have to return for another test, maybe even return 2 times if they divided the test into 2 days. So that was one important finding in this study. Another one, and more importantly, we saw that seemingly the use of ICA was constant over time. It didn't change. However, if we looked at the signal in the ICA, how was the signal to noise ratio, we could see that fewer caths were normal over time. And also that the rate of revascularization was increasing. So the signal to noise favored over time, or became better. And also an important finding was that we saw that the use of a functional test, or the availability of a functional test before coronary revascularization, increased over time. The functional test we defined as myocardial perfusion imaging, or positive FFR, or positive FFRCT test, or FFR-IFR. Of course, this study is inherently a problem due to time bias and so on. So hence, you, of course, had to do adjusted analysis. We used propensity score matching, and here I'll just show you the most important results, I think, in an adjusted analysis, comparing the MPI era with the steady-state FFRCT era. Here you can see that there was actually a decline in the use of ICA, 4%. There was also a decline of 13% in the occurrence of normal coronary arteries in cath after coronary CTA. And we also saw an increase in the use of revascularization of around 15%. And also, importantly, we saw that the availability of a physiological test before revascularization, which a priori is a good thing. You should know what to stent rather than just stent a stenosis, also increased to 28%. So with these results in mind, we thought that, okay, now we've seen FFRCT works. It's feasible. You can use it. And more importantly, it seems to have a higher diagnostic yield than do MPI. However, only in low intermediate pretest risk patients. So this propagated another thought in our minds that why don't we try to use this promising methodology on everybody who comes into our clinic, irrespective of their pretest risk? Of course, as a prerequisite, they should not have known coronary artery disease. They should be de novo patients. So this was what we agreed to do together with our interventionalists and also, of course, the leaders of the department. So we changed our paradigm as of January 1st, 2016 into upfront CTA in every patient with optional FFRCT, of course. The first 6 months in this period, we have reported our results in this paper that Jonathan also mentioned. And the purpose of this paper was to test frontline coronary CTA with selective FFRCT in high-risk patients, especially to assess the influence on downstream ICA and what follows from ICA, namely revascularization. And also, very importantly, of course, the safety of such a procedure. Nobody, to our knowledge, has done this before, so of course we were obliged to test this. This was very important. We defined high risk in this study as classical angina. Some would say, okay, why did you do that? Because that's not what guidelines tell you. No, that's true. They tell us to use Diamond-Forrester risk score. And had we used this, we would only have very few patients, so-called high risk. But we have to remember that this is an arbitrary thing, low, intermediate, and high risk. And just look at what people actually are doing out there. for example, this paper by Baval and co-workers, you can see that patients having typical angina, they have a very high likelihood of having significant coronary artery disease. And also in this paper, you could actually see the very poor signal of stress imaging. That's another discussion. So we defined high risk as classical angina. We agreed to use the same scheme as before, however, in a modified version, because we thought, at least we thought that we had become more wise. So we would, in intermediate lesions, we would use FFRCT as a gatekeeper to the cath lab. And we also introduced the new concept of a supplemental FFRCT in patients in whom we thought ICA would be relevant in any way, but we would like to elucidate perhaps the functional meaning of another lesion than the exact lesion leading to us referring the patient to ICA. So this is what we call a supplemental FFRCT, but the primary focus was in this. And we also elaborated somewhat on our interpretations of the FFRCT results. Of course, we have grown, I don't know whether we've grown wiser, but more experienced at least. And we, in this study, agreed only to send the patients with FFRCT values below 0.75 in accordance with the first study. We're having focal stenosis in one or in the first or in the second segment of the coronary arteries to ICA. All other patients we sent to optimal medical treatment and follow-up. Diffuse disease we define as a non-focal FFRCT change. You often see that. I'll show you an example later on. Or also a focal stenosis in peripheral coronary arteries. We're not that concerned about such changes. So these are the results. It's rather busy. I apologize for that, but it's just to give you an overview. We included 774 patients. 21 patients could not be included. They were not suitable for CTA. And just to show you, the pretest risk over here was 31%. It was a little bit lower than what we have reported in the previous papers. But over here in the high-risk patients, it was much higher. It was more than twice as high, 67%. And for comparative purposes, you can, for example, compare to the invasive arm of the platform trial, where you've got a Diamond-Forrester risk score on average, as far as I remember, 51 or 52%. So these patients, they were really a priori rather sick in their coronaries, at least according to the Diamond-Forrester risk score. Another thing here was, of course, that as expected, you would see that these patients, of course, were older and enriched regarding risk factors, as would be expected. Also, as you can see here, somebody in our department did not do what we told them to do. And that's what happened when you don't do a protocol study, when you just do I nearly would call it an open-label real-world study, as we did. Of course, you have to take into consideration the patient's preferences and so on, the doctor's preferences. So this is what happens. Somebody will send the patient away from the CTA department to ICA directly. These patients were actually older than the ones over here going to ICA after CTA. But their Diamond-Forrester risk score was the same, namely 70%. We had 97% conclusive CTAs, and this is only due to our extremely dedicated staff who are they show a lot of scrutiny and really dedicated in adhering to guidelines. They won't go home before the patient has received a huge amount of beta blockers and nitroglycerin, so that we can be perfectly sure that these images will be perfect for us to look at. And we also saw a conclusive FFRCT rate of 99%. And that's also, of course, these two things are interconnected. As expected, you can see that there were, of course, a lot more coronary artery disease in this group, as you can see here, exemplified, for example, by the Agathon score, which was 320 over here, rather high. And this is the most important of the findings we did in this study, I think, namely the cancellation rate of ICA. You can say that over here, it's arbitrary to talk about cancellation of ICA, because normally you wouldn't send these patients to ICA, but for comparative purposes, the relative impact of FFRCT, that's the orange, that's what is added when putting FFRCT on top of CT, was 23% in relative terms. In absolute terms, a little bit less. However, that's not as interesting as over here. We saw that actually a relative increase in the cancellation rate of ICA of 66% from 46%, which actually isn't that bad. And that's again due to the very good image quality that we received from our technicians, up to 75% when using FFRCT. So, having said this, of course, we also have to address what about the signal-to-noise ratio downstream, so to speak. What about the patients up here? If we take the previous one up here, the ones going to cath, what about them? Overall, we had a revascularization rate of 54%, which isn't that bad. In a normal context, in a normal Danish context, where I should tell you also that in Denmark, CTA is used upfront in a lot of centers. It's very prevalent. So you see an overall revascularization rate in, for example, Western Denmark of about 40%. So this is not bad. If we look a little bit more into the data, the 28 patients who were sent away from the CTA for some reason, I don't know why, directed to ICA, only 28% were revascularized, whereas the patients over here going to CTA and following the CTA path, having FFRCT performed in some of them as a gatekeeper, we only investigate FFRCT as a gatekeeper in this context. You see a revascularization rate of 76%. This is comparable to what we saw in the platform trial that I mentioned before, but however, as I told you before, we saw a much higher Diamond Forest risk score in this study compared to the platform study. This is just a graphical depiction of what I just showed you. I don't want to use your time on that, but let's jump on to the clinical adverse events. That was a safety issue. We defined serious adverse events as hospitalization due to myocardial infarction or death from any cause, either be it coronary or non-cardiac. Cardiac or non-cardiac, sorry. We saw one myocardial infarction here in this group and 2 non-cardiac deaths. And over here, 1 cardiac death in 1 patient going to ICA. No serious adverse events in the patients having ICA canceled at 90 days short-term follow-up. So, from this, we conclude that it seems feasible and also safe, at least at short-term, to use CTA as a frontline test if you do it properly. If you assure that you do right and good examinations each and every time, if you are very stringent in adhering to guidelines regarding having good quality, image quality, then it may be feasible, it may be safe at short term. It may also convey a very high rate of cancellation of ICA and also a very high rate of revascularization. So, having told you about these results, I would like to spend the rest of my presentation together with you in sharing a couple of cases with you, giving you some examples of how we address these problems or patients in everyday life. This is a case of a 68-year-old male with classical angina. His echo and ECG are normal. He's a smoker, and nobody has given him any medication. One wonders why, but nevertheless, the patient was referred for a CTA. We did a calcium scan and saw, if you can see it here, otherwise I can tell you it's almost 4,900. So my next question to you is, how would you, at your institution, go on with this patient? What would you prefer? Would you, in addition, of course, to optimal medical treatment, which I am sure we all can agree upon, would you go for MPI, would you go for CTA, or would you go for invasive cath? Okay. So it's almost all the same signals before. 60% would go for invasive CAF, and 42% would go for ICA. Sorry, that was mumbo jumbo. I said that 60% would go for CTA and 42% for ICA. Okay, that's interesting. So we did, of course, go for a CTA in this patient. As you can see here in these curved MPR representations of the coronaries, I should emphasize that we never use this for diagnostic purposes. This is just to show you the case. The coronaries are heavily calcified. We can't exclude severe coronary artery disease. That was at least what we thought in this particular case. So what would you do next? Would you do an MPI, FFRCT, or would you go for CAF? So 70% would go for FFRCT. Yeah, I like that. So that's what we did also. But we also went for CAF. So everybody's right in this poll, because the patient was actually upfront referred for ICA. However, the one of us looking at this CTA thought that, okay, there might be something wrong on his right coronary artery, and I want to give the full picture to the interventionalist. So I would just order a supplemental FFRCT, and that is what we did in this particular patient. So as you can see here, there's clearly a problem in the left main here. It was picked up by the FFRCT analysis. There is a color change from here to here. And there was also a problem here in mid-LAD with a severe stenosis here. It was picked up also by the FFRCT analysis. And as you can see here, the left circumflex is occluded. It was picked up also here by the FFRCT analysis. We couldn't see that actually on the CTA. There was contrast. Yes, there was contrast because the LCX was retrogradely filled from the RCA. And of course, as you can see here, there's also a severe plaque in the proximal RCA here, also picked up by the FFRCT analysis. The patient did not have FFR measurements done. I think that's perfectly understandable. This is quite enough for the patient to go to CABG, which was the treatment that the patient received. And you can also say that the FFRCT analysis of this patient did not change the course for this patient. But however, we've seen several of such cases where it actually would have changed the course also after the CAF. But in this particular case, it would not have made any difference. I just like the beauty of it because it's so beautiful that everything was picked up by the FFRCT analysis. And here we see why we did like this. It was deemed as high-risk anatomy. We sent the patient to ICA, and we ordered an FFRCT as a supplemental test. And actually, why do we do this? It's a frequent problem to see heavy calcification in patients with high risk. Of course it is. We know that. And we're confident with this and using FFRCT also in these patients. Amongst others, due to this paper by Bjarne again and co-workers, an NXT sub-study, where Bjarne investigated the correlation between FFR and FFRCT in patients over quartiles of Agathon scores, as seen here, and compared the performance in the upper quartile to the other ones, and there was no significant difference. So, of course, there's a clear signal. One would be surprised otherwise, but it was not significant. So FFRCT holds through, although there is here very severe calcification. But you have to take into consideration here again, when there is heavy calcification, it becomes even more important to adhere to guidelines regarding securing the image quality, like using different kernels and small field of view and scrutinizing the patient, like looking at whether the coronaries have been sufficiently vasodilated and the pulse is under control, and et cetera, et cetera. So the last case, and afterwards I will rest my case, but this is a 73-year-old male patient, also with classical angina. He's got a left ventricular ejection fraction of 45%. His ECG is normal. He's got risk factors accordingly treated like this. He's referred for CTA. One could actually say, according to European guidelines, if he's got revascularization potential, he should actually be referred directly to ICA. He wasn't. He was referred to CTA as we agreed upon in our department. So this is his Agathon score. We have a Agathon score of 636, if you can read it. It's moderately elevated. Here are his coronaries, his CTA. As you can see here, there's diffuse disease. There may be a problem here. And there definitely was a suspicion on a problem here in the mid-LAD of contrast thinning here. So we had a suspicion that there could be a moderate stenosis here. So according to our local guidelines, we prescribed a FFRCT analysis here, showing that it looks like this. On the RCA, FFRCT value of 0.77. On this left circumflex, 0.84. And in the LAD, it was actually the lowest value was on the diagonal of 0.78. So my last question to you, ladies and gentlemen, is what to do next? What would you prefer? Would you give the patient optimal medical treatment? Would you go for optimal medical treatment and perfusion imaging, or would you order an ICA? Yeah. So I think that the majority agrees with me, at least, on only going for optimal medical treatment. This is at least what we chose to do in this particular case. The patient is here, so we chose optimal medical treatment and follow-up. The patient is a typical example of what we call, and just go back here, distal tip positivity. There's no focal severe drop in FFRCT values here. So this is distal tip positivity. We rarely and only very rarely send such patients directly to cath. We usually see them in our outpatient clinic and treat them with medication. And this is also the case in this patient, who was actually very happy when we saw him in the outpatient clinic. So with this, I conclude my talk, and I would be happy to answer any questions if I can. And I'll leave the microphone to you, Jonathan. Thank you for your attention.
Thank you so much, Jesper. Honestly, that was a really tremendous talk. I mean, so many excellent teaching points, and you walked us through the history that has been the Aarhus program so thoughtfully. Really appreciate your time and the effort that went into that. There's so many questions that jump to my mind right away. I'll open it to the floor for questions, but before I do, maybe I could just two comments. I think one thing that for many of us North Americans in the Jaha paper, which which your group recently published just a couple of weeks ago, you looked at the impact of FFRCT and you reference MPI imaging. I think many North Americans may not realize that MPI in Aarhus was not even SPECT. It was PET imaging with quantitative myocardial blood flow. So, and despite that, you saw a significant reduction in non-obstructive disease. My question is actually, though, around the notion of the supplemental FFRCT. I think that's a really interesting point, and something that Bjarne and I have spoken about, and I've spoken with others, the notion that even when you're no longer dealing with the patient of question of whether or not the patient goes to the cath lab, but you're actually ordering it to inform decision-making around revascularization strategy. And I just was wondering if you could comment a little bit further, and how integrated are you in providing that information to your interventionalists? Has it empowered a true heart team around the management of CAD the way we do in TAVR, or is it more you simply provide the FFRCT map and the interventionalists review the data, or how does it work?
It's a good question, Jonathan, because actually we did this on a case-to-case basis. So the first prerequisite is that one of us decides, is it relevant to provide the interventionist with additional information. So you of course, there should be a reason to do it. That's the first thing that you should ask, and that's what we do as CT cardiologists. The next question is, of course, as you asked, how do our guys upstairs, the interventionists, how do they use this? And I can't give you a simple answer because I think it's individualized. I think they're, as we are, they do whatever they think is right. And we haven't done a protocol study. So actually, and it would be very difficult to do this, kind of elucidating how was this influencing our interventionist. How did that influence their decision making without kind of influencing their decision a priori, if you understand what I'm meaning. So so it's difficult to elucidate, but what I can show you is actually that a funny, if you can call it funny, a little find that we actually had in this paper also. I don't think we published this because they took it out of the supplemental, but I think we refer to it in the text actually, that we saw saw something peculiar here, a little bit interesting, that if you look actually here at the use of FFRCT as a supplemental test, you can see here, of course, everybody got an ICA per definition, but if you look at the use of IFR or FFR at the decision of the interventionist, you could actually see that when we provided them with a normal FFRCT result, that occurred in 6 cases. It prompted them to measure, can this really be true? So they performed FFR, IFR. That might elucidate, or that might indicate, okay, they believe in FFR. They have to be reassured. Is this true? So that could be one explanation. The other explanation, which is more obvious, is of course that these patients up here are probably more ill a priori. So we don't felt the need for or they don't felt the need for doing additional FFR, IFR. I don't know whether that answers at least part of your question.
No, it really does, and I think it speaks to some of the data embedded in platform that's often not reviewed. But in the invasive arm of platform, you saw a reduction in CABG and relative increase in PCI with FFRCT interrogation, and I think it speaks to reclassification of patients and the limitations of visual assessment of revascularization strategies, and just providing more information going into the cath lab with a deeper understanding of not just the anatomy but the lesion-specific ischemia. So that's it's a really thoughtful, interesting approach.
I have a question, Jonathan.
Hi, Lou. Is that you?
Yeah, Lou Wetzel in Kansas City.
Hi.
First, thanks very much, Jesper. That was fantastic.
Thanks.
Our early experience, the invasive cardiologists feel that the FFRCT is very good in proximal lesions and proximal to mid lesions. They have raised questions, and I think we have good data to show that it's not so. There's not such good correlation in distal, small vessel distal lesions. Would you agree with that observation?
Well, we haven't looked into that because we didn't perform a systematic analysis of this in our data yet. But it may be true, and maybe it's not that surprisingly because
when surprising at all.
No, to me it makes good sense. So when you got a proximal lesion, you measure. It's also a question of where do you measure the FFR? That's for sure, because how do you ensure that you got correlation? Because what they did in the next trial and so forth, the other trials, the FACTOR and so forth, was a core lab ensuring that the correlation was 100%. When you do this in real world practice, it becomes difficult because and the more distal you get, the more difficult it becomes. So that might be one explanation that you see a better correlation in proximal lesions, that you're better able to kind of target your measurements invasively. But I think also it's also important to recognize that we should not, and I do not, consider FFRCT as a substitute for FFR. The primary purpose of doing an FFR doing FFRCT is to keep the patient out of the cath lab, unless it's necessary to get the patient in. So Yeah, exactly. So,
although your supplemental approach, Jesper, I think is really disruptive there. It's like looking at that step, right? That sure, you keep them out of the camp, but really are enriching the decision making. I think that's the way forward. And as you also highlight in the high-risk population, even CT alone excluded the need of the cath lab in a significant number of patients. So, I think you've just debunked a lot of this myth, and that's why we saw the nice guidelines that high-risk patients don't belong in CT. I think you showed very nicely that we don't know what risk really is because Diamond Forcer overestimates risk. And look at the power of your data. It's really, really impressive.
Yeah, sure.
And I would just add, I think we will gradually begin to expand FFRCT even in the high-grade proximal LAD lesion because we want to know what the other vessels do. I mean, I really think that's going to happen.
Well, that's that supplemental approach for sure.
Yeah.
For sure.
Well, I just had
a case
2 weeks ago just like that.
Yeah.
Any other questions from anyone else before we close the session? Okay, well, there being none, thank you so much, Jesper, again, for taking the time.
My
Corey,
pleasure.
Thank you, and thank you for teaching us all so much, and your entire team, and Corey and your team from HeartFLow, thank you for facilitating this opportunity for all of us to get together and share some ideas. I believe Kavitha Chennaiyan is confirmed for the next webinar. It's going to be on cardiac CT in the ED, and then the supplementary role of FFRCT in the population that she and Gil Raff have been pioneering at the Beaumont. So that's coming in November. You'll see an email to that effect. So thank you all again for joining.